Good to go, sir.
Hello students, good evening. I hope you're all here for this session for organophosphorus compounds poisoning. Yep. Good that, yeah, I hope I'm audible and everything is good. Hi, good evening. Myself, Dr. Nileshraj, your faculty for pharmacology. And before starting this session regarding organophosphorus compounds, I just request you to download the workbook which is there in the chat box or in the comment box itself. Please download that workbook because I don't completely rely on pure like one-sided teaching. So notes taking is also going to be very much important for your exams. The next like 40 minutes or like 45 minutes will be completing the discussion for organophosphorus compounds poisoning. And this notes you can utilize it for your exams too. So please make sure you have a good backup, at least for your exam revision purposes. So with this session, with this basic introduction, we'll start discussing the organophosphorus compounds. Before discussing further, let's have a basic introduction regarding what exactly are the receptors of acetylcholine. See, before moving further, why are we talking about the receptors of acetylcholine? Why? Because there are lots of areas to be discussed regarding organophosphorus compounds. Please make sure that these molecules are purely cholinergic stimulators. These are all cholinergic stimulator agent. It will stimulate the cholinergic receptors inside the body. That's why we need to know what are the locations of muscarinic, what are the locations of nicotinic, so that we can have a basic understanding of what exactly we are looking at. What exactly is acetylcholine? Of course, some of you who are going to be appearing for the exams in like, I think like 1 month or 2 months of time, you would have been knowing it. I will explain that in a basic concept, no need to worry. Acetylcholine is a neurotransmitter. For example, if we have an automatic organ in the body, this automatic organ might be heart or GI, smooth muscles, or bladder or bronchus, anything is going to be. If we have an automatic organ, and this automatic organ is going to be supplied with certain neurons. These neurons, if they are cholinergic neurons, it will be releasing out a substance called as acetylcholine. This acetylcholine, which is released from those neurons, it will be binding with certain receptors on the surface of individual organs to produce certain responses. These receptors with which is going to be binding up with, it might be of two major subtypes. These receptors might be muscarinic or it might be nicotinic. Receptors might be muscarinic or nicotinic. Muscarinic, why? Because muscarin, no, Amanita muscaria, the mushrooms or magic mushrooms, if you want to put up, will be binding with those receptors. And why are they called as nicotinic? Because, of course, nicotine is going to be binding up with those nicotinic receptors. Please note that muscarinic receptors might be of 5 major subtypes: M1, M2, M3, M4, and M5. 5 major subtypes of muscarinic receptors. Similarly, nicotinic can be of 2 major subtypes, NM and NN. Muscarinic receptors are all G protein coupled receptors, GPCRs. Muscarinic receptors are all G protein coupled receptors, whereas nicotinic receptors are all called as ionic channels. To prevent the confusion, what we're going to be doing is we're going to be calling up the muscarinics as muscarinic receptors, simple, and call the nicotinics as nicotinic channel, because to remember that those receptors are actually ionic channels and these receptors are muscarinic receptors. G protein coupled receptors, actually they are of many different subtypes. Most classical 3 major subtypes are GS, GQ and GI. Out of all this, the most common one is going to be GS and GQ. Of course, there is going to be GI receptors which are present on the presynaptic terminal. Explanation about what exactly are those G protein coupled receptor is a different LAQ, buddy, long answer question. So we'll be discussing that separately in one more session which is going to be there. But currently, as we are sticking on to organophosphorus compounds, I'll just give you one small take-home point to understand the responses. Please note that GS receptors, if that receptor is a GS receptor, it will be producing If that receptor is a GS receptor, it will be producing smooth muscle relaxation and cardiac muscle contraction. This is a basic logic, buddy. Any smooth muscle is going to be situated, this GS receptor will be producing relaxation. Just give me some examples. If it is binding up with like what your smooth muscles is going to be producing smooth muscle relaxation, simple. So before moving further, let's have a small hi to all those guys who are attending here. Hi, Aditya, Abdul, Karthik, Sanjay, Surya. Hi, good evening, good evening. Thank you so much for being here. Yep, we'll proceed further. Good. Smooth muscle relaxation and cardiac muscle contraction, which means just consider if this GS receptor is there on the vascular smooth muscles, it will be producing vasodilatation. And if it is there on the cardiac muscles, it will be producing cardiac muscle contraction. On the contrary, GQ receptors will be producing smooth muscle contraction. Here, for understanding about muscarinic receptors, it's more than enough to know about GQ receptors. Why? Because this muscarinic receptors M1, M2, M3, M4, and M5, all these are, as I've told, G protein coupled receptors. All these will come under the basic clauses Q, I, Q, I, Q. This is the mnemonic, remember that, my dears. Muscarinic receptors, 5 major subtypes. Remember with this mnemonic Q, I, Q, I, Q, which means M1 is GQ, M2 is GI, M3 is GQ, M4 is GI, M5 is GQ receptors. Moving on to the nicotinic channels, as I've told, both NM and NN are ionic channels. Ionic channels means it is going to be taking control of the influx and efflux of certain ions. And here it is going to be taking control of the influx and efflux of sodium ions. It's not going to be controlling of efflux because sodium is mostly of an extracellular ion, which you have discussed in physiology itself, body. So sodium influx will be taken care of by the NM or NN receptors. With this basic introduction regarding what exactly are the receptors and what are its or simply the nature of those receptors, let's have an explanation regarding what will happen if that receptor is getting stimulated. Primarily, 3 important receptors are there, my dears. The first one is M1, we have M2, and we have M3. 3 major receptors are important for the clinical symptoms of any molecules. Let's first talk about the first receptor, which is M1 receptors. This M1 receptor is there in the enteric nerves. It is there in the enteric neurons. It's there in enteric nerves, which means it is going to be involved in gastric acid secretion. It's going to be involved in the gastric acid secretion. It is also there on the central nervous system. It is also there in CNS, primarily responsible for some concepts called Alzheimer's disease. We'll discuss that later again, don't worry. M2 receptors is actually there on the presynaptic terminal. M2 receptors are there on the presynaptic terminal. M1 is GQ coupled, M2 is GI coupled receptors. This M2 is also situated in the heart. Please note this is an important complex. M2 receptors are also situated on the heart, not only on the neuron. See, when I talk about presynaptic receptors, here we're talking about, here consider this is the muscle, any smooth muscle or any automatic organ. We have the cholinergic neuron. On the presynaptic terminal, there will be expression of one more receptor, and that is what called as GI coupled receptor. What happens is, consider there is impulse which is coming down from the brain, which releases acetylcholine. This acetylcholine will go and bind with certain receptors on the postsynaptic terminal to produce certain responses. But at one point of time, to prevent too much activation of those receptors, there will be a self-control which is happening there. And that automatic control is what called as GI coupled receptors. These GI receptors will be expressed out. The concept of this GI receptor is when the next molecule of acetylcholine is getting released, this acetylcholine will go and bind with those receptors, which in turn will block the further release of acetylcholine. So GI receptors are inhibitory ones. It will prevent the release of its own neurotransmitter. Simply, we can put forth like, this is the neurons, the impulse is coming down from the brain. From the brain, whatever be the impulses, there will be a local control of the release of the neurotransmitter. And that control is provided by the GI coupled receptor. You know about glaciers, right? Glaciers are nothing but from which the river are actually being produced. Similarly, this from the CNS, understand this, from the CNS is what the glacier is, the river is constantly being produced, and this is what a dam is which is constructed, that will block the responses, that will block the water. Whenever it is necessary, it will be releasing it. Whenever it is not necessary, it is going to be blocking it. Well, that's what the concept of understanding what exactly is the primary impulse and what exactly is the impulse due to GI coupled receptors. Here we are talking about M2, which is there on the presynaptic terminal, of course. But here we have certain receptors, the same GI receptors, which might be there on the postsynaptic terminals too. And that is what heart is for M2 receptors. In heart, what it does, because it is an inhibitory receptor, it will decrease the heart rate. It will decrease cardiac conduction or impulse conduction from the atrium towards the ventricles. And also it will decrease the cardiac contraction, which is very much minimal. The decrease in cardiac contraction will be very much minimal. Simply put, it will decrease the heart rate. It will decrease the cardiac conduction. Contraction effect will be very much less with acetylcholine when it is interacting with the M2 receptors. Moving on to the next one, M3 receptors. What exactly are the functions and its locations? We have a mnemonic here, my dears. EGMP, ACBB. EGMP and ACBB. EGMP, ACBB. Yes, I'm getting up all the informations here. Thank you so much. I'm getting all the informations. Thank you so much, buddy. EGMP, ACBB. This is a mnemonic. Remember the locations and functions of M3 receptors. E is for exocrine gland secretion. E is for exocrine gland secretion. G is for GI motility. G is for GI motility. M and P. M is for meiosis due to pupillary sphincter contraction. Meiosis due to pupillary sphincter contraction. AC is nothing but accommodation due to ciliary muscle contraction. B and B. B is for bronchoconstriction and bladder constriction or contraction, anything which you want to remember. This is a mnemonic, my dears, EGMP and ACBB. With this, we're going to be explaining a little bit further. What will happen whenever exocrine gland is getting stimulated? Because it is an M3 receptor. M3 receptors are GQ coupled receptors. GQ means, what was the formula which I have told about? Smooth muscle contraction. Exocrine glands is going to be contracted. So what will happen? The secretions will be increased. Well, that's the take-home point. Exocrine gland secretions will be increased, like salivary glands or lacrimal glands or even the sweat glands. All these secretions is going to be increased because of interaction with the M3. GI motility, GI smooth muscles. What will happen when a GQ receptor is getting stimulated? Formula, don't worry. I'm just going to be explaining the formula. You are going to be coming up with what exactly is going to be happening there. I told you the formula. GQ means smooth muscle contraction. I told you second point, M3 receptor is a GQ coupled receptor. And I have told the location of it. It is there in GI smooth muscles. It will produce GI smooth muscle contraction. GI motility will be increased. Meiosis via pupillary sphincter contraction. Accommodation via ciliary muscle contraction. Bronchoconstriction, bladder constriction. All these will be following the same formula. GQ receptors will be producing smooth muscle contraction. Of course, there are lots of like exceptions, like in some areas, GS will be producing contraction. Some areas, GK will be producing relaxation. Those are very rare exceptions. Don't follow behind that. What about the major ones? We'll be having that formula. And that's the take-home point over here. Is it good? This is the primary like basic introduction regarding the receptors of acetylcholine. Moving on to the next one, acetylcholinesterase enzyme activity. See, acetylcholinesterase is an enzyme which is responsible for breakdown of acetylcholine. For example, consider here is where the any cell or any automatic organs. On the surface, we have this G protein coupled receptor, which are mostly muscarinic receptors, or it might be ionic channels. I'm just giving you an example of a G protein coupled receptor. Whenever acetylcholine is getting released, this will bind with this molecule. Acetylcholine will bind with muscarinic receptors This acetylcholine will be having two major things on its surface. Acetylcholine will be having two sites on its surface. Now, whenever the action of this particular molecule is getting completed, acetylcholinesterase enzyme will come and bind with the acetylcholine and tend to break it down. Acetylcholine will be broken down by acetylcholinesterase enzyme. Please note that esterase enzyme is one of the most powerful enzymes in the body. Any molecule, if it is broken down by an esterase enzyme, the half-life of that particular molecule will be very, very less because the esterase enzymes are very powerful ones. A similar concept can be explained for peptidase enzymes too. Esterase and peptidases are very much powerful enzymes. Now what happens is, here is where the acetylcholinesterase enzyme will come and bind with both of these sites. What exactly are those sites called as? This site is called as anionic site, whereas this site is called as esteratic site. Anionic site and esteratic site. And here is where the acetylcholinesterase enzyme is going to be situated. Acetylcholinesterase enzyme will bind, or simply, this is how the enzyme is. This is the acetylcholinesterase enzyme, and below is where the muscarinic receptor is. This enzyme is coming and binding with it, producing this molecular responses. We have the esterase enzyme. This esterase will come and bind with both the anionic and esteratic site. Thereby, it is going to be breaking down acetylcholine to choline and acetic acid. Don't worry about the breakdown products. This is how the response of acetylcholine is getting stopped. This is the basic introduction, buddy, how acetylcholinesterase enzyme is producing its responses. Now, let's look into the drug names and we'll come back to that diagram. We'll be drawing certain points about those again. Let's talk about acetylcholinesterase inhibitors, as we can see in your workbooks. And again, I just want to remind you, those guys who are joined late, please try to download the workbook, which is there in the comment box and also in the chat box, so that you can have an easier notes to be taken up for the future references. Acetylcholinesterase inhibitors can be of two major subtypes, either reversible drugs or irreversible agents. Reversible means drugs which is binding with acetylcholinesterase enzyme and inhibiting it in a reversible way. A similar or a different concept for irreversible inhibitors. It will bind with it irreversibly. Within these reversible enzymes, we have neostigmine, physostigmine, pyridostigmine, edrophonium, rivastigmine, donepezil, galantamine, and tacril. Before explaining further, I'm just looking at the comment box, my dears. Thank you so much, everyone. Thank you so much, everyone, for joining here for the session. And I'll be just putting up a small question here, and that question is, out of this neostigmine and physostigmine, which tend to cross the blood-brain barrier? A very famous question, no? Which tend to cross the blood-brain barrier? Anyone who can answer this question? Out of this, neostigmine and physostigmine, which will cross blood-brain barrier? A very famous question, frequently been asked in lots of different exams. Yes. Any messages from your side? Yeah, any inputs? Yes, beautiful. The answer is yes. I'm getting the responses. The answer is physostigmine. It's a small concept, buddy. Please understand this. Physostigmine is there. It tend to cross blood-brain barrier. Physostigmine will cross blood-brain barrier. Neostigmine will not cross blood-brain barrier. Just a small level to be understood. Yes, you're right, Dr. Karthik. You're right. Physostigmine tend to cross blood-brain barrier. Beautiful answer. So remember, this mnemonic: physostigmine will cross, neostigmine will not cross blood-brain barrier. Don't get confused in the future also. Now, let's move on further. Regarding irreversibles, we have parathion, malathion, ecothiopate, carbaryl, and propoxer. Parathion, malathion, and ecothiopate are all organophosphorus compounds. Whereas carbamate and propoxer, these two molecules are carbamates. We can call it as carbamates itself. One important carbamates is there, which is carbaryl. Carbaryl and propoxer, these two molecules will be called as carbamate group of drugs. Right. Now we'll move back to this previous page and we'll draw the explanation regarding how these molecules tend to produce its own responses. Consider again, here is where the cell is. On the surface, we have the receptor. 1, 2, 3, 4, 5, 6, 7. Because it's a G protein coupled receptor, we'll draw 7 lines across the membrane. Of course, you know that basic logic's there. Now, again, here is where the acetylcholine molecule is. We have the acetylcholine molecule, which is binding up with these receptors. Now, when you administer a reversible inhibitor, a drug which is going to be binding up with acetylcholinesterase enzyme in a reversible manner, now what will happen is, normally we will be having the acetylcholinesterase enzyme, which contains 2 sites. The first site is called as esteratic site. The first site is called as anionic site, and the other one is esteratic site. Now try to answer this, try to think of this in a basic way. We have 2 different molecules. One molecule is a reversible inhibitor. The other one is an irreversible inhibitor. Logically, to explain, reversible inhibitors will bind with 1 site. Irreversibles will bind with 2 sites. But here, that logic is not going to be there. The answer is going to be inverse. Reversibles will bind with both the anionic and esteratic site. Reversible acetylcholinesterase inhibitors will bind with both anionic and esteratic site, whereas irreversible inhibitors are there, which will bind only with esteratic site. Irreversible inhibitors will bind only with esteratic site. This is anionic and this is esteratic. Please note that irreversibles will not bind with the anionic site. Simply put, as I've told, esteratic site is a stronger bond. Anionic site is an ionic bond, which is a weaker bond. The bond which is formed with the esteratic site is going to be a little bit stronger, or the bond is going to be in a covalent form if there is no hindrance with the anionic site. Whenever both of the anionic and esteratic site is getting bounded, there is more chance that the bond which is formed is very much weaker. That's why the action is going to be reversible in nature. Irreversibles will bind with esteratic site alone. Reversibles will bind with both anionic and esteratic site. Now, we have one more area to be explained. Before that, we'll go back to the drug names and we'll talk about individual drug names under that. Neostigmine is a drug which can be used for the treatment of cobra bite. Neostigmine can be used for the treatment of cobra bite. In case of snake bites, we can go with the neostigmine in combination with atropine. Physostigmine can be used for the treatment of belladonna poisoning. Belladonna poisoning, or even for atropine overdose, we can administer physostigmine. Pyridostigmine is a drug which is used for the treatment of myasthenia gravis. Pyridostigmine is the drug which can be used for myasthenia gravis. Now comes the most important topic. Edrophonium is the drug which can be used for diagnosis of myasthenia gravis. We have a famous test called a stencilon test, but anyhow, we don't use it on a common basis. But why edrophonium alone is being used for this particular condition, for diagnosis? Why? Because edrophonium is a reversible inhibitor. You're right. Again, we have the same acetylcholinesterase enzyme, anionic site and esteratic site. Here is where the edrophonium is. Edrophonium will bind only with the anionic site. It has got no bounding with the esteratic site. This is anionic, esteratic, and this binding is seen with edrophonium. So simply, edrophonium is a drug which will bind only with the anionic, and that's why the action is very much shorter. It has got a very short duration of action. Because of this mechanism, it can be easily removed back on a frequent basis, and also it can be excreted out quickly. Because edrophonium is binding with only with the anionic site, point number 1, and point number 2, because it is highly excreted out via the kidneys, the action is very much short-living. That's why we use edrophonium for the diagnosis of myasthenia gravis. What about rivastigmine, donepezil, galantamine, and tacrin? All these drugs are used for the treatment of Alzheimer's disease. Alzheimer's disease, we use all these drugs except for tacrin. We don't use tacrin because tacrin produces very severe hepatotoxicity. That's why we don't use that drug currently. Tacrin is associated with very severe hepatotoxicity. Now move on to the most important topic for today, and that is organophosphorus compounds. So why did we explain about lots of basics? You will understand why these basics are very much important, because all these points, you're going to be filling it out by yourself. Organophosphorus compounds, we have parathion, malathion, ecothiophate. As I've told, we have carbamates, which are carbaryl and propoxyl. Now let's move on further. Organophosphorus compounds, very much commonly used previously, but now it has been highly replaced with lots of newer drugs, less toxic agents. But anyhow, any farmer, if they are getting exposed to organophosphorus compounds, either accidentally or suicidally, they might get exposed to OPCs. If a patient comes up with organophosphorus compounds overdose, what exactly are the symptomatology which can be expected? As you can see in that workbook which we have administered, acute toxicity and intermediate toxicity or intermediate symptoms. Acute toxicity is something which will manifest within minutes to hours of ingestion. Minutes to hours of ingestion, we can see what exactly is the response from the patient. These symptoms will be seen. Now, again, we have a mnemonic here. We have two mnemonics, very much old one, sludge BBB or dumbbells. Two different mnemonics are there. Very famous. When I was a child, I was being told that mnemonic. So very much old mnemonic. But let's first complete the mnemonic and we'll go back to that symptomatology. Sludge and triple B, yes, is for salivation. There will be more amount of salivation. L is for lacrimation. Patients will be crying. U is for urination, increased urinary output. D is for defecation, increased GI motility. Again, GI motility will be increased. GI motility will be increased. And E is for emesis. Patients might land up in vomiting. Triple B, B is for bradycardia. The first B is for bradycardia. We have bronchoria. Bronchoria means increased secretions from the trachea, increased secretions from the bronchus. And B is for bronchospasm. Bronchospasm. A very famous mnemonic, sludge and BBB. But either you can go with that mnemonic, remember that. But if you feel it difficult, don't worry. All these we have already explained, my dears. You remember that M3 receptor and M2 receptor? What exactly are the locations and functions, my dears? M2 receptor is situated in the heart. Yes, if you couldn't remember, please go back and take a look at that notes which you have written. M2 receptors are there in the heart. In heart, it will produce decreased heart rate, and that's why we have bradycardia. Again, bradycardia is due to the stimulation of M2 receptors because these are all acetylcholinesterase enzyme is getting inhibited by organophosphorus. Increase acetylcholine, more acetylcholine will interact with the muscarinic and nicotinic receptors to produce certain symptoms. Bronchoria, increased respiratory secretions or secretions will be increased by M3 receptors. Bronchospasm, how it is getting seen? Yeah, in that which you have written, AGMP and ACBB, the last B is bladder contraction. And before that, we have bronchoconstriction. And that's why M3 stimulation will produce bronchospasm. Salivation, again, M3 receptors. Lacrimation, M3 receptors. Urination, because of bladder smooth muscle contraction, M3 receptors. Defecation, increased GI motility. All these things are because of M3 receptors, because that's what we have written previously. That's it. I'm not going to be saying out loud. If you could know the receptors, its nature and its functions, that's it. There is no need for mnemonics. Even if you want, you can go with this old mnemonic, sludge and triple B. Now we'll move to the next one. There is something called as intermediate syndromes. What exactly is intermediate syndrome? Intermediate syndrome means this will be manifesting within 24 to 76 hours after the exposure of that particular organophosphorus compounds. It will not be seen on an immediate basis. After 1 day or after 2 days, we can start seeing these kind of symptoms. What exactly are those? We have a mnemonic here. BURP is the mnemonic. BU stands for bulbar muscles, which are there. R is for respiratory muscles. R is for respiratory and P is for proximal muscle. Proximal muscle, over the shoulders, like kind of things. All these muscles will be land up in weaknesses. There might be weakness of all these muscles. Burp muscle weakness is the mnemonic. Remember the intermediate syndrome associated with organophosphorus compounds. Now, similarly, we have certain long-term or delayed responses. We have certain long-term or delayed responses. After administering this drug, there might be some responses which can be seen after years of this OPC poisoning. And that is what called as organophosphorus induced delayed neuropathy. Organophosphorus induced delayed neuropathy, which is also called as OPIDN. OPIDN means organophosphorus compounds induced delayed neuropathy. Now, we have acute symptoms, we have intermediate symptoms, and we have chronic symptoms or delayed symptoms, which can be seen after a very long amount of time after getting exposed to organophosphorus compounds. But the query here is, why a patient die? When can we expect a patient to die because of organophosphorus compounds? A patient can die even at 5 minutes of exposure to organophosphorus, or even after 12 to 24 hours after exposure of organophosphorus compounds. It is primarily based on the amount of OPCs to which the patient got exposed. We can't come up with a single number like exactly at 8 minute 50 seconds, 56 minutes, the patients will going to be dying. No, we can't do that. This is primarily based on the amount of OPC which the patient has consumed and amount of OPC which has gained entry inside his blood. Now, if a patient is going to be dying because of organophosphorus compounds, what might be the reason behind? Of course, it's going to be one of these things, no? Acute toxicity. So which part of acute toxicity patients might die? The answer for this question is going to be bronchospasm. Because of bronchospasm and also because of bronchoria, patients might land up in respiratory failure. This respiratory failure is also because of CNS activity, buddy, because organophosphorus compounds are highly lipid soluble in nature. It will cross the blood-brain barrier to produce central symptoms. When it's gaining entry inside the brain, it might block the respiratory center. It might inhibit the respiratory center. That's also one of the reasons why patients might land up in respiratory failure. Some patients, because of bradycardia, which can be developed, might land up in heart block, and some patients might land up in QT prolongation. Bradycardia is not the primary reason for heart block, my dears. Of course, you would have known it. The heart block is primarily because of, yes, one more M2 receptor. What's the activity of one more M2 receptor? M2 receptors will produce decreased heart rate. The second one, decreased conduction of impulses from the atrium towards the ventricles. When that conduction is getting blocked, the patients might land up in heart block. Simple logic, don't worry. So these are the mechanisms of how toxicity will be developed and how we can identify a patient with symptoms, what are the intermediate symptoms and long-term symptoms of organophosphorus compounds poison. Now we'll move on further. Let's explain regarding what exactly is the treatment process. Well, that's how we are here for now. Most importantly, the treatment for a patient with OPC poisoning. We have certain non-pharmacological therapies and pharmacological therapies. In majority of the books, it will be classified as non-pharmacological therapy, but oxygen, of course, it's a drug. We have to commit it under pharmacological therapies, but anyhow, if a patient is suffering from severe hypoxia, we can go with 100% oxygen given as face masks. And if necessary, some patients might land up in severe respiratory depression. There might be a need for intubation to be there. And if there is a chance of respiratory or a rapid sequence intubation, if you want to put up intubation and you want to put up an artificial respiration, you have to give a smooth muscle, you have to give a skeletal muscle relaxant agent to produce or to initiate the intubation. The commonly used drug in practice for initiating intubation in terms of any type of RSI processes, we used to go for succinylcholine. But here, succinylcholine is contraindicated. Why? Why succinylcholine is contraindicated? Because the problem itself is too much amount of acetylcholine, buddy. The problem here itself is too much amount of acetylcholine. If you give succinylcholine, that will further, it might further worsen the symptoms. Is that right? And most importantly here, whenever the organophosphorus compounds is getting administered, the organophosphorus compounds are inhibiting the acetylcholinesterase enzymes. Succinylcholine in turn might be accumulated inside the blood because the mechanism or metabolism is not going to be happening. Not only acetylcholinesterase, even pseudocholinesterase or butyrylcholinesterase also is going to be inhibited. Because of accumulation of succinylcholine, the skeletal muscle relaxation will be there for a very long time. Up to 8 hours, we can expect that. And that's why succinylcholine should not be administered in these patients. Which drug can be preferred? Rocuronium can be preferred. Rocuronium, that too given at high doses, can be used for RSI, rapid sequence intubation, for a patient with OPC poisoning. Volume resuscitation, we can administer ringer lactate or even normal saline solution. We have to make sure the volume is getting balanced out. Within 1 hour, if the patient has been brought within 1 hour of conception, we can try decontamination. These organophosphorus compounds are very much highly absorbable. So if it is within 1 hour, we can try for decontamination, and that too with activated charcoal. Around 50 grams we used to administer. Activated charcoal around 50 grams can be administered in terms of adults. The function of activated charcoal is, this is what we call as physical antagonism. This is actually called as physical antagonism. Antagonism means this will physically block the absorption of the drug which has been administered, or organophosphorus compounds which has been administered. That will at least stop the entry of the drug inside the blood. That will prevent the worsening of the condition. That's why activated charcoal can be given at an early response, not after delayed response. After like many hours of the patient is being given, if they are taken to the hospital and most of the drug is getting absorbed, what's the use of giving activated charcoal? Usually it will not be necessary at those times. Dermal or ocular irrigation, we have to go with severe washing of all the skins and washing of the eyes, if at all there is an exposure to those. Why? Because these OPC poisonings are highly lipid soluble agents. So there might be something called as contact absorption. There will be something called as contact absorption. Contact absorption means the drug might get absorbed whenever it is getting exposed to your skins. From that itself, the drug might gain entry inside the blood. So what happens is the patient is getting admitted with OPC poisoning. You start the patient with the regular therapies, but constantly you couldn't get the patient out from the OPC poisonings because slowly the absorption is going to be happening on a constant manner. That's why dermal irrigation, the areas, exposed parts where all he might get thrown off to this OPC has to be washed off to prevent further entry of that drug inside the blood vessels. The last one, discard the clothing. Good. These are the non-pharmacological managements. Moving on to the most important, pharmacological management. See, I don't know whether you know it or not. We have a small rhymes which most of the children used to sing. Even my child used to sing that rhymes. And that rhyme is something called as roly, roly, roly rhymes. It's a very famous one. I've seen him singing it by himself. And that thing goes roly, 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 up, up, up. Roly, 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 down, down, down. Roly, 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 out, out, out. Roly, 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 in, in. Roly, 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 slowly, slowly. Roly, 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 quickly, quickly, quickly. So totally we have this, this is the full rhyme which I was singing out. We're going to be utilizing it for organophosphorus compound. Simple. We'll start with the first one. Roly, 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 up, up, up. Up means there will be CNS symptoms associated with organophosphorus compounds because OPC poisonings will cross the blood-brain barrier to produce CNS symptoms. Roly, 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 down, down, down. Patients will be urinating, patients will be defecating. All these things is going to be going down from the body and going up of the body. Roly, 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 out, out, out. Oh, out is for oximes, which can be used for the treatment of OPC poisoning. Roly, 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 in, in, in. In is for atropine to be used in treatment for organophosphorus compounds poisoning. Roly, 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 slowly, slowly. Oximes has to be administered on a very slow IV. Why? We'll explain that in a few minutes. Roly, 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 quickly, 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 which means atropine has to be administered at a faster rate. Atropine has to be given very much quickly at a bolus doses, IV bolus, we have to administer atropine. With this knowledge, we'll explain about the pharmacological management. I hope you know what exactly are the drugs which is used, oximes and atropine. Let's start with the first one, atropine. What exactly is atropine? Atropine is an anti-muscarinic drug. Atropine is an anti-muscarinic drug, the first important point. What is the dose of atropine which we administer? Simple logic, my dears. Here, acetylcholinesterase is getting inhibited. Acetylcholine is getting accumulated. More acetylcholine will be interacting with the muscarinic receptors to produce certain symptoms. That's why we give an anti-muscarinic drug. When we block that, acetylcholine will not bind with that receptor. Immediately, we can get the patient out from the symptoms. That's why for acute therapy, we have to administer atropine for those patients. Usually, what's the dose which is administered? Usually around 2 to 5 milligrams has to be administered on an IV route, slowly or fastly. Quickly, we have to administer atropine. And we have to go with the dose escalations. The dose might be doubled. The dose might be doubled every 3 to 5 minutes. Every 3 to 5 minutes, we can double the drug dose. Till what point? A very famous question. See, there are lots of symptoms of OPC poisoning, no sludge and BBB. Till what symptom is getting corrected, we have to administer atropine. Lots of notes are there which tend to say till the heart rate is getting normal. Some notes tend to say till the eye reflexes are getting normal, till we can see the mydrias, because normally it is producing meiosis, no? Because it's producing contraction. Here it might produce mydriasis. Anticholinergics will produce mydriasis. All these symptoms will not be there. Please note that heart rate or mydriasis, these two things are not a specific sign for stopping the therapy with atropine. The correct one is till bronchoconstriction is getting relieved, till the patient's respiration is going to be normal. Because whenever a patient is suffering from organophosphorus compounds overdose, he might be having difficulty in breathing because of respiratory muscles insufficiency. In those conditions, patients might be landing up in hypoxia. Whenever patient lands up in hypoxia, that hypoxia itself might be producing this increase in heart rate, might be producing ocular symptoms. And that's why we can't keep it as therapeutic endpoint. If you keep it as therapeutic endpoint and you stop giving atropine, actually the patient is still suffering from OPC poisoning. So you shouldn't do that. We have to wait till bronchoconstriction is getting relieved. And sir, what if the bronchoconstriction is not getting relieved? Then we can add adrenaline. If bronchoconstriction or if the symptoms are not getting relieved even after continuous administration of atropine, we can administer adrenaline for those patients. Now, what exactly are the symptoms which are getting relieved? Of course, muscarinic symptoms will be relieved. If nicotinic symptoms are developed, it will not be relieved for the patients. Why? Because we know atropine is an anti-muscarinic drug. Yes. See, when you administer an organophosphorus compounds, what happens is the acetylcholine levels will increase. More acetylcholine will interact with the muscarinic receptors to produce certain symptoms. But what about nicotinic channels? These molecules also might bind with the nicotinic channels to produce certain symptoms. What exactly are the nicotinic symptoms? We'll go back to the first page. We'll finish off the nicotinic areas. Let's say we have left a small gap over there. NM and NN receptors. NM channels is actually there at the neuromuscular junction. NM is there in the neuromuscular junction. NM means nerve and muscle junction, buddy. That's it. So consider this is what the muscle is, and this is where the cholinergic neuron is. From here, there is release of acetylcholine, which will bind with NM receptor. NM receptor, which gets opened, might tend to release or increase the influx of sodium. Sodium will gain entry inside the muscles, which will produce muscular end plate depolarization. Thereby, the skeletal muscles is going to be contracting. That's the normal response of NM receptor or NM channel on getting stimulated. A similar concept will be there for NN, which is going to be there in the ganglia, autonomic ganglia. Because in nerve, presynaptic or preganglionic and postganglionic neuronal junction, and here is where NN receptor is, and that is responsible for ganglia to be stimulated. I hope that I'm clear till now. But don't worry about ganglia stimulation. But don't worry about ganglia stimulation. Here, the primary response which you should remember is regarding NM receptor. So as I've told previously, M2 receptor, M3 receptor, and NM receptor, these three are the primary receptors which are responsible for symptoms in terms of organophosphorus compounds. Now, what happens when the patient is taking up OPC? There will be too much amount of acetylcholine, continuous interaction with the NM receptor, which is present in the neuromuscular junction. It will produce increased skeletal muscle contraction. There will be twitching and fasciculations initially. But because of continuous contraction or because of frequent contraction which is happening over the skeletal muscles, at one point of time, the sarcoplasmic reticulum will be losing up calcium. The calcium will be lost from the sarcoplasmic reticulum, which in turn will produce relaxation of the muscles. The muscles will stand up into relaxation. Even if the acetylcholine is released, the contraction is not going to be evident because the effect is going to be decreased after some point of time. Well, that's the reason usually we can't see a nicotinic activity very much highly in some patients. Mostly muscarinic activity will be overtaking, nicotinic activity will not be overtaking the muscarinic responses. Shall I tell you one more thing? One more thing is there in mathematics. And the mathematics rule is for stimulating muscarinic receptors, we need one molecule of acetylcholine. For stimulation of nicotinic channels, we need two molecules of acetylcholine, which means I can expect either only muscarinic symptom in the patient or both muscarinic and nicotinic symptom in the patient, but I can never expect nicotinic channel alone to be expected in the patients. Good. Now, with that concept in mind, we'll go back to this. As atropine is purely an anti-muscarinic drug, we can be producing reversal of muscarinic symptoms, but nicotinic symptoms will not be relieved. This is currently the drug of choice. This is currently the treatment of choice for organophosphorus compounds and carbamates poisoning. Organophosphorus compounds and carbamates poisoning. But let's talk about the most important one here, and that is oximes. You remember that? Roly, 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 in is what atropine is. And I told that roly, 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 quickly, quickly, quickly. We have to administer it on a quicker basis. The same roly, 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 out, out, out is nothing but oximes. Oximes example, we have pralidoxim. Pralidoxim, we have obidoxim, and we have lots of other drugs, diacetyl monoxim, which is also used in biochemistry too. So these molecules are also called as acetylcholinesterase reactivators. What exactly is that? Oh my God, it's a new terminology. Acetylcholinesterase reactivators. Guys, don't need to worry. I've just explained that's a small concept, very small concept. Again, consider here is where the acetylcholinesterase enzyme is. Yep. And here is where the organophosphorus compounds is. The organophosphorus compound is binding only with the esteratic site. Of course, everyone knows it. Organophosphorus compound will bind only with the esteratic site. Now, what happens is, because of this binding, the acetylcholinesterase is not binding up with the acetylcholine to break it down. Now, when you administer this molecule, which is organophosphorus compounds, which is called as oximes, this oximes will go and bind with the esteratics, will bind with the anionic site at first. Oximes will go and bind with the anionic site of acetylcholinesterase enzymes. By binding with that, it will be having a seat to sit down. Thereby, it forms a bond with the opposite molecule. And what is that? Organophosphorus compounds. It forms a bond with the organophosphorus compounds. Thereby, this whole molecule is going to be displaced out of the acetylcholinesterase enzymes. So here is where the this is your oximes. And here is where the OPC molecule is. This whole thing is going to be taken out of the acetylcholinesterase enzymes. Now, acetylcholinesterase enzymes will be reactivated, which in turn will go and bind with acetylcholine, break it down. That's the concept here. Now here, what I'm trying to express is, we can put it up in words as, previously, we have the acetylcholinesterase enzyme, which has bonded with the organophosphorus compounds. Now, when you treat the patient with oximes, you know what happens? This oximes will bind with the organophosphorus compounds to produce a molecule called as phosphooxim complex. It will produce a molecule called as phosphooxim complex. As the name itself implies, phospho means organophosphorus. Oximes means the oximes or pralidoxim which was administered. Because of this complex, it will be thrown out from the body. The acetylcholinesterase enzyme is getting reactivated. That's why these molecules are called as acetylcholinesterase reactivators. The next one. What's the usual dose which we administer? We used to administer around 2 grams via IV route. As I've told, is it going to be faster or slower? We have to administer it on a slower basis. That's why we have to administer it for 30 minutes. Bolus dose must be given for 30 minutes. Slowly we have to administer. Why not via rapid route? What if I administer it via rapid IV? It happens, it might produce cardiac arrest. Patients might develop cardiac arrest, but it's the first important adverse effect. The second one is, patients might further progress on to more respiratory failure or muscle weakness. Sir, how come, sir? How come there will be more chances of respiratory failure or muscle weakness? Understand this, buddy. Consider we have 10 acetylcholinesterase enzymes, right? In the body, we have 10 enzymes. When the patient is taking up organophosphorus compounds as suicidal or accidentally, this organophosphorus compounds is binding and inhibiting 6 of this. Only 4 is functioning, and that's why the patient is still alive. Now the patient is brought to you, heart rate is there, bradycardia is there, everything is there, but the patient is still alive. Now what? You administer oximes as a fast therapy. Now what will happen when you administer oximes? Oximes, it will produce reactivation of acetylcholinesterase enzyme. It will bind with which site? Yeah, anionic site of all these 6 different acetylcholinesterase enzymes, and it will try to remove out the organophosphorus compounds. But the same oximes will also bind with the anionic site of the remaining 4 molecules too. When those remaining 4 molecules also will be blocked, there will be a transient acetylcholinesterase enzyme inhibition by oximes itself. That's the take-home point here. There will be a transient inhibition of acetylcholinesterase enzyme by the oximes itself. To prevent that, it shouldn't be administered as rapid IV. It has to be administered as slow IV. The first point. The second point is it must always be administered along with atropine. To prevent, as I've told, transient acetylcholinesterase inhibition. Transient acetylcholinesterase inhibition, we have to administer it always along with atropine. So the treatment is simple, buddies. Either you administer atropine or you administer atropine with oximes. Sir, atropine is doing a good job. Why should we administer oximes? You remember those 3 major signs of toxicity: acute toxicity, intermediate and long-term toxicity, or delayed toxicity. OPIDN, opioid or organophosphorus compounds induced delayed neuropathy. And that delayed neuropathy can be prevented only by oximes. Organophosphorus induced delayed neuropathy can be prevented only by oximes. Atropine will not prevent the development of OPIDN in the future. So it is advisable to add oximes even if the patient is appropriately in a normal way. Atropine alone might be enough, but we have to add oximes to prevent the future complications from developing. Now the next one, if we have administered the bolus dose of around 2 grams is given via IV route. After that, we have to change the patient to 8 milligrams per kilogram per hour IV infusion. So do we need to remember the drug doses? Yes, only for emergency conditions. For chronic conditions, no need to remember the drug doses. For emergency conditions, it's always advisable to remember the drug doses. And this can be used for muscarinic symptoms and also for nicotinic symptoms. This can be used for the treatment of organophosphorus compounds poisoning alone. It cannot be used for carbamates poisoning, buddy, because carbamates tend to have a rapid aging process. The aging process is very much rapid to be developed with carbamates. What exactly is aging process? Aging process is nothing but aging processes when you administer organophosphorus compounds in combination with acetylcholinesterase enzyme. What happens is it will take some time. It's not been clear cut in any of the reference boxes to say after what time exactly. But after like few times, more than like 12 to 24 hours, some books tend to say 12 to 24 hours. This whole molecule, see, this is where the organo or acetylcholinesterase enzyme is, and here is where the your organophosphorus compound is. There will be an initial smaller bond with which the patients will come up with symptoms. But if the patient is not being treated, this bond is going to be a very much stronger bond. It will form an irreversible inhibition, and that process is what we call as aging process. This combination or organophosphorus compounds, when it binds with acetylcholinesterase enzyme, it will be converting a normal acetylcholinesterase enzyme to mono alkoxy phosphoryl acetylcholinesterase, MAP acetylcholinesterase. Some books tend to say MIP acetyl mono isopropyl phosphoryl. Goodman-Gilman says mono-alkoxy phosphoryl acetylcholinesterase enzymes. The conversion of a normal acetylcholinesterase to mono-alkoxy phosphoryl acetylcholinesterase enzyme, that's the concept called as aging process. This aging process will be very much quicker with carbamates. That's why oximes, it will take a longer time to start producing its responses. That's why it cannot be effective for carbamates poisoning. Also, one more point is there. The second point is carbamates, there is no free anionic site. The anionic site is not free for carbamates, my dears. Simply, carbamates will be binding up with anionic and esteratic site. Now, the issue here is, as I've told, you remember this diagram? Oximes are binding with the anionic site. If that site is not free, oximes will not be effective in treating those particular conditions. Well, this is the full take-home point regarding organophosphorus compounds, buddy. Before closing this session, we'll be having a test question also. Try to answer this question. Farmer with organophosphorus compounds poisoning was treated with IV atropine and pralidoxim. After that, he presented with hyperthermia. The temperature increased. What could be the reason for the presenting complaint? Here, the question is an MCQ, multiple choice question. Organophosphorus compounds poisoning. Try to answer this. OPC poisoning patients will land up in what? Hypothermia or hyperthermia? Sludge, remember that mnemonic? Sludge. S is for salivation, L is for lacrimation, U is for urination. One more thing is there, sweat secretion. This sweat secretion will be very much high for a patient with OPC poisoning, which means the temperature will drop down. So hypothermia will be seen with cholinergic agents. Remember this? Cholinergic agents will be producing hypothermia, whereas anticholinergic agents will be producing hyperthermia. Temperature is going to be increased by anticholinergic agents. We have something called as atropine fever. So here the patient is actually suffering from atropine fever. So this is exactly a side effect of atropine. Side effect of pralidoxim, very much minimal, buddy. Mostly patients might land up in some respiratory failure. Mostly patients will not be having any major contraindications to be usages for pralidoxim too. Aspiration pneumonia, it is not possible. When aspiration pneumonia comes because of infection, patients might land up in hyperthermia, but that is not possible over here. So here the answer for this question is direct side effect of atropine overdose. Good. Now, what exactly is the model question? I have given you a model long answer question. For your exams, the model question is going to be, they will be giving up to you with the symptoms and they'll be asking you for the diagnosis of it. The 20-year-old was brought to the emergency room after consuming some unknown substances. This is a question about poisoning. I'm going to be underlying those which you used to call as clinchers. Clinchers means by certain words, we can come up with the diagnosis. And those words are, the patient was sweating profusely, the first point. Saliva was drooling, salivation from the mouth. Tears were present, more lacrimation, sludge. S has been completed, L has been completed. He has involuntary urination, U, and diarrhea, D, that's it. On examination, his heart rate was 58 beats per minute, one of the B's which has been given. So what exactly are those? Out of the sludge BBB, we have seen SLUD, and also we have written about B also. So the question is going to be for organophosphorus compounds overdose. Here the model question states, what is the most probable diagnosis? You have to write up with, please, whenever you come across these kind of questions, please don't blandly write OPC poisoning. Please don't blandly write it. You give the justification for that. How to proceed, how to write up the answers for this? You have to come up with, as the patient is suffering from severe profuse sweating, saliva, lacrimation, urination, diarrhea, and the patient is suffering from bradycardia. The above symptoms are due to the stimulation of M3 receptors. The heart rate is due to the stimulation of M2 receptors, which are due to overactivity or cholinergic crisis. Because this patient has consumed an unknown poisoning, most probably the answer is going to be a muscarinic drug overdose. Muscarinic overdose, most importantly or most commonly, patients might land up in OPC poisoning. You cannot give a definite diagnosis with the symptoms. So presumptively, we can diagnose the patient as OPC poisoning. That's it. That's how we have to write up the first question. Please take that as a norm for any question we're going to be writing up in the future. Please don't blandly write OPC or blandly write the diagnosis. You give up the justification for that. Second, write a brief note on pharmacological and non-pharmacological managements of this patient. You know the treatment of it. Yes, non-pharmacological oxygen and all the other things. Pharmacological atropine and pralidoxim. Explain the mechanism of action. We have explained it with a beautiful diagram. Just draw the diagram. Don't worry. So when you come across this question, I request you to draw the diagram of acetylcholinesterase enzymes, the mechanism of irreversible ones, Just draw the normal acetylcholinesterase, draw the diagram of irreversible inhibitors, draw the diagram of oximes. These three diagrams should be there in that answer papers. And you go with the flowchart which I have told regarding atropine and the pralidoxim or any other oximes. Don't forget to write down the nuances, small points which has been explained previously. Write down the non-pharmacological managements, and when you come up with the diagnosis, please justify the diagnosis. With this, we complete today's session, buddy. Thank you so much for attending. And from the next session onwards, I think it's a bit difficult to continue that in YouTube. Please move on to Doc Live. I'll just give you how to proceed further, how to install this Doc Live app. It is very much free. No need to worry. It's available in Play Store. Download the Doc Live app first. The step one, it's available in Play Store and also in the app stores. You download the Doc Live app, which is there in both of the stores. Download it. Create an account. For new users, you sign up for DocTutorials app, or you can go with DocTutorials website and get an account which is signed up. For already existing users, you can log in with your same DocTutorials credentials itself. Those students, those students who don't have any DocTutorials credentials, please download the DocTutorials app and get the credentials from that. Open the Doc Live app. There will be we have to log in with your DocTutorials login account details. Navigate to the live sessions. We have a separate tab for there. Click on those live sessions. There will be oncoming sessions or ongoing sessions and upcoming sessions. You click on the ongoing sessions and you click on any session which you want to attend. Join the live sessions. One important advantage of joining that is here, because we are going up with this, the interaction is very much lesser, where we can have a separate like chat box where we can look up into what are the queries and doubts which are raised by you. The interaction is going to be very much detailed, and I request you to download this Doc Live app. And from the next session onwards, we'll be discussing lots of long answer questions, targeting more of LAQs and targeting more of SAQs, expected questions for your exams. So make sure that you attend all those sets and you write down your notes and make sure that you're having those notes just before the exams. Go through that notes. You'll be landing up in a very good marks. Thank you so much, and we'll meet up in one more session. This is Dr. Nilesh signing off.